Welcome to the module on hematopoietic stem cell transplantation, or HSCT. My name is Lauren Ice, and I am a transplant clinical pharmacy specialist at Spectrum Health in Grand Rapids, Michigan. I care for both autologous and allogeneic transplant patients in the inpatient and outpatient settings. This presentation is part of the ASHP-ACCP Oncology Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. The activity is designed to be interactive with questions posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answer and the correct response in your handout. The disclosures are displayed on this slide. There are 4 learning objectives covered by this presentation and the accompanying handout. The handout does contain more material than the slides, so I will be referring to it for additional information. Our first objective is to design an appropriate treatment, supportive care, and monitoring plan for transplant patients based on clinical trials and guidelines. And secondly, to discern strategies to prevent toxicities from chemotherapy agents used in transplant conditioning regimens. We will also create a plan for the prevention and management of graft-versus-host disease, and finally, discuss short and long-term treatment goals and survivorship. We'll start with our first patient case and audience response question. KB is a 72-year-old woman with relapsed diffuse large B-cell lymphoma. She achieved a complete response after 3 cycles of R-ICE for her relapsed disease. What is the most appropriate therapy for KB at this time? Options are A, Beam-R myeloablative conditioning followed by autologous transplant, B, busulfan and fludarabine reduced intensity conditioning followed by autologous transplant, C, busulfan and fludarabine myeloablative conditioning followed by allogeneic transplant, or D, anti-CD19 CAR T-cell therapy. The recommended treatment for a diffuse large B-cell lymphoma patient with a complete response, meaning they have chemosensitive disease, in first relapse would be myeloablative chemotherapy followed by an autologous transplant. Beam-R is a standard myeloablative regimen utilized for B-cell lymphoma, so the best answer is A. Busulfan and fludarabine reduced intensity regimen followed by an autologous transplant would not be appropriate as a myeloablative regimen is indicated. A myeloablative allogeneic transplant is not recommended before an autologous transplant due to increased toxicity. And the currently approved indications for anti-CD19 CAR T-cell therapy are in patients who have relapsed or refractory disease after 2 or more lines of therapy, so the patient does not currently qualify. HSCT is a vital component of the armamentarium for many life-threatening malignant and non-malignant diseases. A great review of HSCT indications and the level of evidence for their use can be found in the American Society for Transplantation and Cellular Therapy, or ASTCT, guidelines that are referenced on this slide. This table just provides a snapshot of some of the standard of care indications for adults. For example, for myeloma patients with an initial response or sensitive relapse, an autologous transplant is recommended. An autologous transplant is also recommended for Hodgkin lymphoma and diffuse large B-cell lymphoma patients with sensitive primary refractory disease or first or greater sensitive relapse. Allogeneic transplant is recommended for patients with AML in CR1 for intermediate and high-risk patients, or CR2 for all patients, with similar indications for ALL and for intermediate 2 or high-risk MDS. These guidelines also make recommendations for when transplant is not recommended or there is little information available to support. For the remainder of the presentation, we will be walking through the entire transplant process, including the events before and after transplant. This diagram shows some of the workup and process leading up to transplant. This process can start any time from years to months before transplant, all leading up to the day of transplant, which is also referred to as day 0. Everything prior to that is counted as negative numbers, and after day 0, everything is counted in positive numbers. So for example, day plus 100. The first steps for all transplants are referral and evaluation of eligibility, which encompasses things such as age, performance status, disease assessment, social support, and insurance coverage. And for allogeneic transplant, the donor search and eligibility testing is also initiated early. Moving to the next box, following the referral and donor search, we'll discuss mobilization and collection of stem cells, which typically occur in the weeks before day 0. And that's then followed by the conditioning regimen, and for allogeneic transplants, immunosuppression is started. And this all occurs prior to the stem cell infusion. So over the next several sections of slides, I will highlight key information for pharmacists in the pre-transplant process. Although as pharmacists, we may not be intimately involved in donor selection, it is important to understand the clinical implications of different donors for allogeneic transplant. The preferred donors are a matched related donor, or MRD, followed by a matched unrelated donor, abbreviated MUD. And this is due to superior survival and transplant outcomes. If not available, the alternative options include those listed across the top of this table: umbilical cord blood, haploidentical, which means they share one HLA haplotype, and a mismatched unrelated donor. This table highlights some key points when comparing alternative donor sources, but I want to emphasize the role of haploidentical transplant. Historically, the risks of haploidentical transplant were great and often outweighed its benefits. However, increased experience over the last decade has shown haploidentical transplant with post-transplant cyclophosphamide may be considered as a first alternative option and potentially even above a matched unrelated donor in some instances. Several recent meta-analyses have demonstrated improved non-relapse mortality with haploidentical compared to matched unrelated donors, mismatched unrelated donors, and umbilical cord blood, as well as lower rates of graft-versus-host disease with a haploidentical transplant. Results of a randomized trial comparing umbilical cord blood and haploidentical transplant were just published last month in Blood and showed improved non-relapse mortality and 2-year overall survival with haploidentical transplant. In the real world of clinical practice, many factors are taken into consideration when selecting a donor for allogeneic transplant. The expertise of the transplant center, along with patient and disease-related factors, and availability are likely to determine the most appropriate donor selection. Following patient and/or donor selection, the next steps are stem cell mobilization and collection. Since the peripheral blood only contains approximately 1% of the cells contained in the bone marrow, the goal of stem cell mobilization is to increase the number of circulating stem cells to facilitate peripheral collection. There are multiple patient and treatment-related risk factors for poor mobilization, including older age, bone marrow involvement of the tumor, extent of prior radiation and chemotherapy exposure, especially exposure to certain agents such as purine analogs, lenalidomide, and alkylating agents. There are several methods of mobilization. For healthy donors collecting for allogeneic transplants, stem cells are collected through the use of single-agent G-CSF. For autologous patients, there are 3 main methods: single-agent G-CSF, or G-CSF in combination with either chemotherapy or plerixafor. And I'll briefly discuss pros and cons of these strategies, but I'll refer you to the handout for more detail. Single-agent G-CSF has predictable scheduling and lower drug costs, but failure rates up to 30 to 40%. Chemotherapy mobilization collects more stem cells than G-CSF alone, but it has similar overall rates of failure, and it can be associated with increased costs and toxicity, and it has less predictable scheduling. And finally, plerixafor has the highest CD34 positive yields, the lowest failure rates, and predictable scheduling with fewer apheresis days, but it comes with increased drug costs. It can be used in the upfront setting or preemptively based on factors predicting poor mobilization, like a pre-apheresis CD34 cell count. The next several slides highlight key recommendations from the ASTCT guidelines for autologous stem cell mobilization. For myeloma patients, single-agent G-CSF at a dose of 10 to 16 micrograms per kilo per day is recommended, but only if the patient meets certain criteria, such as no more than 1 line of chemotherapy and no more than 4 cycles of lenalidomide. Preemptive plerixafor can be used for patients with low peripheral blood CD34 counts because this can decrease mobilization failures. If patients have received lenalidomide, it is recommended to collect after 2 to 4 cycles. And both G-CSF with plerixafor or G-CSF with chemotherapy have been shown to be effective in those with lenalidomide exposure. For patients with non-Hodgkin lymphoma, single-agent G-CSF is recommended due to low toxicity and predictability, but it is associated with a higher failure rate in this disease state, so it should be limited to those with low risk of failure. Again, preemptive plerixafor is recommended in the guidelines for patients with low peripheral blood CD34 counts prior to apheresis. And chemotherapy mobilization is very effective and recommended when it can be incorporated into the initial or salvage therapy. In general, use of chemotherapy for mobilization outside of initial or salvage therapy is associated with more toxicity and cost compared to G-CSF alone. Therefore, use should be restricted to mobilization failures. There is a lack of robust data for the upfront combination of chemotherapy plus G-CSF plus plerixafor, and thus it is not recommended at this time and more study is needed. The use of upfront plerixafor is a suitable option for all patients, especially if the institution's goals are the highest number of CD34 positive cells and lowest number of apheresis days possible, or if real-time CD34 cell counts are not available. Most institutions have developed algorithms for preemptive plerixafor use to balance mobilization failures with drug costs. If the first mobilization attempt fails and remobilization is required, single-agent G-CSF should not be utilized. Plerixafor should be added if it was not in the original regimen, which is successful in 70% of cases. Chemotherapy with G-CSF is an acceptable option if the patient failed G-CSF alone. And bone marrow harvest remains as a potential third-line option. Now to introduce case number 2 with another audience response question. SV is a 65-year-old male with AML in first complete remission and is planning to undergo a haploidentical allogeneic transplant. He is scheduled to receive non-myeloablative fludarabine, cyclophosphamide, and total body irradiation as conditioning prior to transplant. Which of the following should SV receive to prevent toxicity from his conditioning regimen? A. Continuous bladder irrigation. B. Phenytoin. C. Ursodiol. Or D. Twice daily skin cleaning. The correct answer is C. Ursodiol, which should be given for the prevention of sinusoidal obstruction syndrome of the liver. Continuous bladder irrigation is not a method that is recommended to prevent hemorrhagic cystitis with cyclophosphamide. Guideline recommended options include Mesna or saline diuresis. Phenytoin or other anti-epileptic medication is required for busulfan therapy, and twice daily skin cleaning is recommended for thiotepa use, neither of which this patient is receiving. Conditioning regimens can serve several purposes for a transplant. These may differ depending on the type of transplant and the disease state being treated, but in general, the conditioning regimen serves to eradicate any remaining malignancy, and for allogeneic transplants, immunosuppress the host so the donor cells can engraft. Conditioning regimens are divided into 3 categories based on the risk of cytopenia and the requirement for stem cell support. Myeloablative regimens, as the term implies, cause irreversible cytopenia, and therefore stem cell support is necessary to rescue patients from hematopoietic failure. All autologous regimens are myeloablative, as that is the goal of the transplant, in addition to some allogeneic regimens. Non-myeloablative regimens are at the other end of the spectrum. They are extremely immunosuppressive, but they cause minimal cytopenias, and therefore stem cell support would not be required to save a patient from hematopoietic failure. These regimens rely heavily on graft versus tumor effect to eradicate remaining malignancy, and they typically consist of low-dose total body irradiation or immunosuppressive agents like fludarabine or cyclophosphamide. Reduced intensity regimens are in the middle. They cause a cytopenia of variable duration, and stem cell support is required, but a patient may be able to survive without. Reduced intensity regimens also rely on the development of graft versus tumor effect, and they usually contain doses of alkylating agents or total body irradiation that are at least 30% lower than myeloablative regimens. You can find examples of common conditioning regimens in tables in the handout. This graph shows how decreasing the myeloablative properties of the regimen decreases the treatment-related toxicity, but increases the reliance on graft versus tumor effect. So starting at the bottom left-hand corner and moving up and to the right, the intensity increases from low-dose TBI, which is 200 to 400 centigray, all the way up to busulfan and high-dose TBI, which is 800 to 1320 centigray. And as the intensity increases, the toxicity of the regimen also increases from top to bottom, but reliance on the graft versus tumor effect decreases. There is an ongoing debate regarding the superiority of myeloablative compared to reduced intensity regimens in allogeneic transplant, and there were two recent randomized controlled trials examining this question. In the first trial listed here by Scott and colleagues, they performed a phase 3 randomized trial comparing myeloablative to reduced intensity conditioning in patients with AML and MDS. In this trial, enrollment actually stopped early due to a significantly higher relapse rate in the reduced intensity arm. Their published long-term results show survival at 4 years was significantly worse in the reduced intensity compared to the myeloablative arm, 49 versus 65%, which was predicted given the much higher relapse rate in the reduced intensity arm. The second trial listed here was a prospective randomized phase 3 trial comparing reduced intensity to myeloablative conditioning in MDS or secondary AML. And in contrast, this study did not find any significant differences in outcomes between the two groups, including 2-year overall survival or relapse-free survival rates. So as stated, this is an area of ongoing debate, but based on the available data, myeloablative regimens are recommended for patients who are thought to be able to tolerate. Hematopoietic stem cell transplant allows the utilization of doses that are 3 to 10 times higher than standard doses, because the infusion of stem cells rescues patients from the hematologic failure that would otherwise occur with these high doses. And thus different toxicities become dose-limiting in the transplant setting. Mucositis is the dose-limiting adverse effect for many of the alkylating agents. For busulfan, hepatotoxicity, neurotoxicity, and pulmonary fibrosis can also occur. Pulmonary toxicity and hepatotoxicity are dose-limiting for carmustine. For cyclophosphamide, doses are limited by cardiotoxicity and hemorrhagic cystitis. Neurotoxicity can occur with cytarabine, fludarabine, and thiotepa. And the next 4 slides will go over some specific chemotherapy supportive care recommendations necessary for transplant patients. Busulfan is a drug with a narrow therapeutic index, and some toxicities have been found to be dose-related. Therefore, pharmacokinetic guided dosing using area under the curve should be used with myeloablative doses. And I refer you to the handout for more details on target AUC ranges. Pharmacokinetic dosing is less well established and not commonly utilized in reduced intensity regimens. Busulfan also causes seizures in up to 10% of patients without prophylaxis. Therefore, routine seizure prophylaxis is required, and agents that have been used include phenytoin, levetiracetam, and benzodiazepines. Busulfan is metabolized through the liver, and it has multiple drug-drug interactions which can affect levels. Carmustine has a dose-related pulmonary toxicity that is much more common with doses above 450 milligrams per meter squared. And this presents as an acute lung injury, and the key is to treat early with high-dose steroids. Hemorrhagic cystitis is one of the main complications of high-dose cyclophosphamide. Prevention can be achieved with Mesna at 60 to 100% of the cyclophosphamide dose, or saline diuresis to maintain adequate urine output. Fludarabine has been associated with neurotoxicity following transplant, and this typically occurs several months after therapy, so it can be difficult to correlate and diagnose. Risk factors include higher doses, as well as older age, renal dysfunction, and prior cranial irradiation. And the most important role for pharmacists is to monitor and adjust for renal function to hopefully decrease accumulation in the CNS. Melphalan is the agent of choice for autologous transplants for myeloma, and its dose-limiting toxicity in transplant is mucositis, but cryotherapy is a relatively simple intervention that is recommended by the MASS guidelines to prevent mucositis with melphalan. Melphalan is primarily eliminated by hydrolysis, but around 10 to 15% of the drug is cleared renally. There's conflicting data on the utility of dose reducing for renal dysfunction, so there is no consensus for adjustments. Finally, thiotepa is used in some conditioning regimens. Its metabolites can accumulate in skin folds and dressings, so it is recommended to avoid occlusive dressings and clean skin at least twice daily during therapy. Returning to our pre-transplant process, after the conditioning regimen is given, the stem cells are infused on day 0 and post-transplant care begins. The rest of the presentation will focus on post-transplant complications and care of the patient after transplant. Unfortunately, relapse of the primary disease is very common after both autologous and allogeneic transplant and is the leading cause of death after day plus 100. There are multiple strategies to try to prevent relapse, including monitoring for residual disease and starting preemptive therapy, withdrawing immunosuppression early to stimulate graft versus tumor effect in allogeneic transplants, or the use of maintenance therapy. Following autologous transplant, there is data to support the use of maintenance therapy in several diseases. Lenalidomide is FDA approved for maintenance therapy following autologous transplant in multiple myeloma and is typically the preferred agent due to a meta-analysis showing improved progression-free and overall survival. Other agents may be considered based on individual risk and benefits. Rituximab maintenance is recommended for mantle cell lymphoma patients after autologous transplant, and this is based on a study published recently in the New England Journal of Medicine that showed improved overall survival. And finally, the guidelines recommend brentuximab maintenance for high-risk Hodgkin lymphoma patients, and this was based on significantly prolonged progression-free survival in a randomized phase 3 study. Several agents have also been studied to prevent relapse in the allogeneic setting. A number of agents have been investigated for AML and MDS in primarily small or non-comparator studies, including agents such as the hypomethylating agents and FLT3 inhibitors. There is currently insufficient data to recommend routine use of these agents for maintenance therapy. However, it is reasonable to consider tyrosine kinase inhibitors in FLT3 positive AML. There are several newly published randomized trials that have shown a reduction in relapse rates when these are used in the maintenance setting. In Philadelphia positive ALL, there is data to support prolonged survival with maintenance TKI therapy. The data is less clear in CML, but a post-transplant TKI can be considered. We will now move on to some early complications of transplant, including GI toxicities, graft-versus-host disease for allogeneic transplant, infection, and other transplant-specific complications. Returning to patient case number 1, KB is a 72-year-old woman with relapsed diffuse large B-cell lymphoma. She is planning to receive high-dose Beam-R conditioning followed by an autologous transplant. Which of the following is the most appropriate to recommend that KB receive to prevent mucositis? A. Sargramestin mouth rinses. B. Doxepin mouth rinses. C. Ice chips. Or D. Palifermin. The best answer is C. Ice chips, which are recommended in the MASS guidelines for prevention of mucositis with melphalan. Sargramestin mouth rinses and palifermin are not recommended in this setting due to lack of efficacy. Doxepin mouth rinses have been studied for treatment of oral mucositis, but not prevention. Mucositis is common following transplant, with reports of up to 70 to 80% of patients experiencing any oral mucositis. The incidence can be affected by the type of conditioning, especially use of agents like melphalan and etoposide, high-dose total body irradiation, and using methotrexate to prevent graft-versus-host disease. The MASS guidelines contain several recommendations to prevent oral mucositis. Oral cryotherapy, as mentioned, is recommended for patients receiving melphalan. Palifermin, which is a keratinocyte growth factor, is recommended in the specific setting of autologous transplant receiving high-dose chemotherapy and total body irradiation. But outside of this setting, it has not been shown to be effective, and it can add significantly to the cost of therapy. Low-level laser therapy is also recommended, as well as oral care protocols are suggested for all patients. For treatment of oral mucositis, the MASS guidelines recommend morphine patient-controlled analgesia and suggest doxepin mouth rinses. Nausea vomiting is also common in the transplant setting. The ASCO guidelines for antiemetics in oncology recommend that transplant patients getting high-dose chemotherapy receive at least a 3-drug combination of a neurokinin-1 receptor antagonist, 5-HT3 antagonist, and dexamethasone to prevent nausea and vomiting. The 2020 guideline update states that a 4-drug combination, with the addition of olanzapine, can also be considered in this setting. The evidence for this is currently limited to a single placebo-controlled phase 3 trial and small retrospective report. The ASCO guidelines also recommend that patients treated with high emetic risk radiation, like total body irradiation, should receive a 2-drug combination of a 5-HT3 receptor antagonist and dexamethasone before each fraction and a day after radiation ends. Now we'll go back to patient number 2. SV is our 65-year-old male with AML in first complete remission and is planning to undergo a haploidentical allogeneic transplant. What is the most appropriate graft-versus-host disease prophylaxis regimen for SV? A. Cyclosporin plus methotrexate. B. Post-transplant cyclophosphamide. C. Tacrolimus plus mycophenolate plus antithymocyte globulin. Or D. Tacrolimus plus mycophenolate plus post-transplant cyclophosphamide. The most appropriate prophylactic regimen for SV undergoing a haploidentical transplant would be D. Post-transplant cyclophosphamide in combination with tacrolimus and mycophenolate is the most appropriate standard of care combination immunosuppression regimen for a haploidentical transplant. And this is based on multiple clinical trials demonstrating acceptable rates of acute and chronic graft-versus-host disease in this population. Options A and B would not provide adequate prophylaxis and would result in higher rates of graft-versus-host disease as well as graft failure. And option C is incorrect, as antithymocyte globulin should not be used in place of post-transplant cyclophosphamide in the haploidentical setting. Graft-versus-host disease is one of the primary complications of allogeneic transplant. It is an immunologic disorder that results from donor T cells recognizing host tissues as foreign and initiating an immune reaction targeting those tissues. It is classified as acute or chronic based primarily on clinical features. Classic acute GVHD occurs within the first 100 days, but late onset acute GVHD after day 100 is also common, especially with reduced intensity conditioning regimens. Chronic graft-versus-host disease typically occurs after day 100, but can occur at any time, and patients can have clinical features of both acute and chronic, which is called overlap syndrome. The most important factor to decrease the risk of graft-versus-host disease is optimal donor selection, which encompasses not only HLA match, but other factors like age and gender. Stem cell source also impacts graft-versus-host disease risk, with peripheral blood stem cells having the highest risk and bone marrow and umbilical cord blood having a lower risk. But as pharmacists, we focus more on pharmacologic prevention. The next few slides will review some practice-driving studies, but the key principle to know is that pharmacologic prevention typically consists of a two-drug backbone of a calcineurin inhibitor, either cyclosporin or tacrolimus, plus short-course methotrexate. Due to toxicities with methotrexate, mycophenolate may be used as an alternative instead of methotrexate, and there is also data to support Sirolimus as an alternative or in combination. We'll discuss the role and controversy of antithymocyte globulin in more detail, but it is another agent that can be added to the standard backbone to help prevent graft-versus-host disease. And finally, post-transplant cyclophosphamide was first developed and is standard of care for haploidentical transplants, in addition to that standard backbone. And there's ongoing research to investigate its use in other transplant types, and we may see it become used more commonly in the future outside of the haploidentical transplant arena. There is an abundance of data demonstrating the efficacy of the combination of a calcineurin inhibitor and methotrexate for prevention of acute graft-versus-host disease. The two trials listed on this slide compare methotrexate with either tacrolimus or cyclosporin in the matched-related and matched-unrelated donor populations. In the first study, tacrolimus had a significantly lower rate of grades 2 through 4 acute GVHD. However, the cyclosporin group demonstrated improved overall survival at 2 years. Based on this study, cyclosporin with methotrexate is considered standard of care for matched-related donor transplants. It is important to note a major limitation of this study was the higher proportion of patients with advanced disease in the tacrolimus group, which could have influenced survival outcomes. In the second study by Nash with matched unrelated donors, tacrolimus again showed improved rates of grades 2 through 4 acute graft-versus-host disease, with no significant difference in other outcomes. Therefore, the combination of tacrolimus with methotrexate is standard of care for matched unrelated donor transplants. Due to toxicities with methotrexate, several randomized studies have evaluated the use of a calcineurin inhibitor plus mycophenolate compared to methotrexate. The Bulwell study, which looked at cyclosporin plus either methotrexate or mycophenolate, actually closed early due to evidence of reduced toxicity in the mycophenolate arm and similar rates of graft-versus-host disease and overall survival. The mycophenolate arm had faster engraftment and decreased mucositis compared to the methotrexate arm. Similar results were seen in the study by Perkins and colleagues. Therefore, mycophenolate is considered a well-tolerated alternative to methotrexate. There have also been randomized studies comparing the standard combination with the substitution or addition of sirolimus. The first study by Cutler compared tacrolimus with sirolimus to tacrolimus with methotrexate in a phase 3 trial of matched-related donors. The authors found no difference in graft-versus-host disease or survival outcomes between the study groups. The Sirolimus group did show a shorter time to neutrophil and platelet engraftment and lower rates of mucositis. However, this was balanced with higher rates of sinusoidal obstruction syndrome and thrombotic microangiopathy. So careful monitoring should occur if this combination is used. The newest data evaluated the combination of cyclosporin, mycophenolate, and sirolimus in the non-myeloablative setting, and it demonstrated improved rates of acute graft-versus-host disease and overall survival. So this combination can be considered in this setting. The use of anti-thymocyte globulin, or ATG, for prevention of graft-versus-host disease is an area that is still controversial, and further studies will hopefully elucidate its role. This topic is complicated by the availability of multiple different products and dosing schemes. The analysis by Kroger and colleagues, published in the New England Journal of Medicine in 2016, compared cyclosporin plus methotrexate with or without ATG in a randomized phase 3 trial in matched related donors. In this study, use of ATG was associated with a significantly reduced rates of acute and chronic graft-versus-host disease and no difference in relapse or overall survival. A more recent study, however, was a double-blind phase 3 study published in the Journal of Clinical Oncology in 2017. While ATG use decreased rates of acute and chronic graft-versus-host disease, the ATG arm also had significantly lower overall survival. Therefore, more information is needed to identify which patients may benefit the most from use of ATG. As described, post-transplant cyclophosphamide is standard of care for haploidentical transplants in combination with other immunosuppressive agents. The pivotal pilot study demonstrating the benefit of post-transplant cyclophosphamide was published by Lesnick and colleagues in 2008. This single-arm study demonstrated the efficacy in preventing acute and chronic graft-versus-host disease with rates of 34% and 5% respectively amongst patients who received cyclophosphamide on days +3 and +4. Another study compared two separate prospective cohorts: haploidentical patients receiving tacrolimus, mycophenolate, and post-transplant cyclophosphamide, and umbilical cord blood recipients receiving tacrolimus and mycophenolate. This study found no difference in rates of acute or chronic graft-versus-host disease or overall survival at 1 year. Many of the medications used for the prevention of graft-versus-host disease have narrow therapeutic ranges and require careful monitoring, including therapeutic drug monitoring for some. The calcineurin inhibitors tacrolimus and cyclosporin can both cause nephrotoxicity and neurotoxicity, in addition to other adverse effects. The recommended trough level for cyclosporin is between 150 to 450, and for tacrolimus between 5 and 20, although 5 to 15 is more commonly used in clinical practice. Toxicities to monitor with sirolimus include thrombotic microangiopathy and hepatotoxicity. The recommended trough range in this setting is 3 to 12, and of note, sirolimus has a long half-life of approximately 60 hours. Therefore, a loading dose may be appropriate when initiating therapy. Although mycophenolate is typically well tolerated, the main toxicities include GI disturbances and myelosuppression. The use of therapeutic drug monitoring has not been well studied in the haematopoietic stem cell transplant setting. Methotrexate has several toxicities, including mucositis and delayed engraftment. Monitoring should include renal function, liver function, development of fluid collections, and mucositis, and these should guide dose reduction or elimination of doses. Continuing with patient case number 2 and our 5th audience response question, SV is a 65-year-old male with AML in first complete remission who underwent a haploidentical allogeneic transplant. He received tacrolimus, mycophenolate, and post-transplant cyclophosphamide to prevent graft-versus-host disease. He presents on day +35 with a maculopapular skin rash on 45% of his body and had 1,200 mLs of diarrhea in the past 24 hours. He is diagnosed with overall grade 3 acute graft-versus-host disease. Which of the following is the most appropriate graft-versus-host disease treatment for SV at this time? A. Ruxolitinib 5 mg twice daily. B. Prednisone 0.5 mg per kilo per day plus beclomethasone. C. Methylprednisolone 2 mg per kilo per day. Or D. Methylprednisolone 2 mg per kilo per day plus infliximab. The most appropriate initial treatment of stage 3 acute graft-versus-host disease would be C. Methylprednisolone 2 mg per kilo per day, which is the guideline recommended total daily dose for treatment of acute graft-versus-host disease. Ruxolitinib is approved for steroid refractory acute GVHD, and option B contains a prednisone dose that is lower than the guideline recommendation. Option D is incorrect for frontline therapy, as no additional systemic agent has shown benefit when added to steroids as first line. Despite our efforts to prevent graft-versus-host disease, anywhere from 20 to 80% of patients will develop acute GVHD. This primarily manifests in 3 organs: the skin, gastrointestinal tract, and liver. Skin is the most common organ involved and usually the first. The classical presentation is a maculopapular rash with or without itching. The GI tract is the next most common organ involved and can present with symptoms varying based on location of involvement. If the upper GI tract is involved, symptoms are commonly nausea, vomiting, anorexia, and dyspepsia, and often weight loss as well. If the lower GI tract is involved, symptoms can include secretory diarrhea, abdominal pain, and in severe cases, ileus and GI bleeding. The liver is the least frequently involved organ and can present as cholestatic hyperbilirubinemia. Liver involvement of graft-versus-host disease can be the hardest to distinguish from other causes of liver injury, such as sinusoidal obstruction syndrome or drug injury. Each organ is individually staged, which is then combined to give an overall grade ranging from 1, which is mild disease, to 4, which is very severe. Treatment is based on severity of symptoms and overall grade. Grade 1, which is involvement of skin only, should be treated with topical corticosteroids, and the original immunosuppressive agent should be continued or potentially increased or restarted if it was recently tapered or discontinued. These recommendations come from both the ASTCT guidelines as well as the relatively new National Comprehensive Cancer Network Clinical Practice Guidelines in Oncology for hematopoietic cell transplant. These guidelines currently cover pre-transplant evaluation and management of graft-versus-host disease, and they are one of the recommended readings for the module. The NCCN guidelines also list observation as a treatment option for grade 1 acute GVHD. For grades 2 through 4, systemic corticosteroid therapy, with or without topical, is recommended in both guidelines. Per the ASTCT guidelines, the recommended dose is methylprednisolone 2 mg per kilo per day or prednisone equivalent, whereas the NCCN guidelines list a range of 1 to 2 mg per kilo per day of methylprednisolone or equivalent prednisone. Literature supports and the guidelines agree that a lower initial starting dose may be used for upper GI tract involvement only, with combination of GI topical steroids such as budesonide or beclomethasone. Again, we should ensure that the original immunosuppressive agent is at a therapeutic level and consider a clinical trial if available. Although many agents have been studied, no systemic agent added to steroids in the frontline setting has shown improvement over steroids alone. Therefore, steroids alone remain the preferred first-line option. If a response is achieved, it is recommended to taper the dose every 3 to 5 days per the ASTCT guidelines. Unfortunately, response rates to first-line treatment range from 50 to 65%, with only 25 to 40% complete response rates. Therefore, a large proportion of patients will have steroid refractory acute graft-versus-host disease, which can be defined a few different ways and vary slightly between the guidelines. There is no standardized treatment for refractory acute graft-versus-host disease, as very few comparative trials have been completed. The data that is available varies in the number of patients treated, the organs involved, the definition of response, and the number of previous therapies, making true comparisons very difficult. There is one FDA-approved agent for steroid refractory acute graft-versus-host disease, which is Ruxolitinib, and we'll describe that in more detail in a couple slides. Since there is no single recommended agent, the choice of second and later lines of therapy should be driven by clinical experience, toxicity profile, convenience, and cost. This table contains agents that have been studied and are commercially available, with reported response rates, and the organ or organs most likely to respond based on clinical evidence. You can see a variety of agents have been studied that target different parts of the immune system and activated immune response. These are typically added to the original immunosuppressive agent and/or steroid therapy, and I've bolded Ruxolitinib as it is the only FDA-approved option. Ruxolitinib was FDA approved for the treatment of steroid refractory acute graft-versus-host disease in May of 2019. The most recent clinical evidence for its use was the REACH-2 study, which was a randomized phase 3 study published in the New England Journal of Medicine in 2020, comparing Ruxolitinib to investigators' choice for steroid refractory acute GVHD. The primary endpoint of overall response rate at day 28 was 62% in the Ruxolitinib arm compared to 39% in the control. And there were also more durable responses in the Ruxolitinib arm. For this indication, it is dosed at 5 milligrams twice daily, which can be increased to 10 milligrams twice daily in the absence of toxicity. And the main toxicities in this setting are hematologic, infection, edema, hypertriglyceridemia, and increased LFTs. Chronic graft-versus-host disease can occur at any time after an allogeneic transplant, but it most commonly occurs after day 100 and within the first 1 to 2 years after transplant. This complication can really affect any organ. Some of the most common are listed on this slide, and there are a number of manifestations that are diagnostic in different organs. These signs and symptoms often resemble autoimmune diseases, and a hallmark sign of chronic graft-versus-host disease is fibrosis. I refer you to the table in the handout for a more detailed chart on signs and symptoms of chronic graft-versus-host disease. In 2015, the National Institutes of Health developed a consensus scoring system, which greatly improved consistency amongst institutions, clinical trial reporting, and just general follow-up measures. The NIH Global Score for Chronic Graft-versus-Host Disease takes into account the number of organs or sites that are involved and the severity of involvement to give an overall rating of mild, moderate, or severe disease. The global score then drives treatment for chronic GVHD. For mild disease, topical therapy alone is appropriate to target the involved organs, along with supportive and ancillary therapies. A great resource and one of the recommended readings for this module is a paper by Carpenter and colleagues published in 2015, and this lists ancillary and supportive care options for chronic graft-versus-host disease by organ system. For moderate or severe involvement, systemic treatment with corticosteroids is recommended, but the recommended dose varies slightly between guidelines. The NCCN guidelines recommend treatment with methylprednisolone 0.5 to 1 milligram per kilo per day, or prednisone equivalent, whereas the ASTCT guidelines recommend prednisone 1 milligram per kilo per day. The ASTCT guidelines also recommend tapering to an every other day regimen, as therapy for chronic graft-versus-host disease typically requires a prolonged corticosteroid course. The NCCN guidelines say to continue or consider restarting the original immunosuppressive agent. Literature supports the combination of prednisone plus a calcineurin inhibitor in patients with thrombocytopenia, which may be an indicator of more severe disease. A clinical trial should always be considered if available. And if chronic graft-versus-host disease affects the lungs, which presents as bronchiolitis obliterans syndrome, the FAM regimen is recommended to slow progression. FAM consists of inhaled fluticasone or other inhaled corticosteroid, azithromycin, and montelukast. Other agents combined with prednisone in the frontline setting have not been shown to be beneficial. So overall, you can see the systemic treatment for chronic graft-versus-host disease is lower than acute graft-versus-host disease, but it does often require much longer therapy duration and sometimes lifelong. Similar to acute graft-versus-host disease, response rates range from 50 to 65% and are highly variable based on organ involvement and degree of change. Patients who should be considered for second-line therapy are those who progress or have new manifestations on their initial doses after several weeks, if they show no improvement after 1 to 3 months of therapy, if they're unable to taper prednisone below certain limits, or if they have a general intolerance to prednisone therapy. As with acute graft-versus-host disease, there are many agents that have been studied in a second-line or later setting, but the information is highly variable, and there is no standardized approach or agent to refractory chronic graft-versus-host disease. Ibrutinib is the only FDA-approved treatment for refractory chronic graft-versus-host disease, and its FDA approval was based on an open-label non-comparator study. Other things to consider when choosing second-line therapy are what organs are involved, the potential toxicities of additional agents, interactions with current therapy, and of course, cost and patient preference. This table includes agents that have been studied in the refractory chronic GVHD setting. Ibrutinib is bolded as it is the only agent with FDA approval for refractory chronic graft-versus-host disease. The organs that showed the highest rates of response with ibrutinib included the skin, oral mucosa, and GI tract. A recently published update of the original study showed overall response rates of almost 70%, with about 30% complete responses. Again, many other agents targeting different pathways of the immune response have been studied. Continuing with patient case number 2, SV is a 65-year-old male with AML in first complete remission who underwent a haploidentical allogeneic transplant. He was tapered off all immunosuppression by day plus 190. He subsequently developed moderate chronic graft-versus-host disease involving his skin and oral mucosa and is now starting prednisone 1 mg per kilo per day at day plus 240. Which of the following is the most appropriate infection prophylaxis for SV at this time? A. Acyclovir, pentamidine, posaconazole, and penicillin. B. Valganciclovir, pentamidine, fluconazole, and penicillin. C. Valacyclovir, sulfamethoxazole trimethoprim, voriconazole, and penicillin. Or D. Acyclovir, sulfamethoxazole trimethoprim, posaconazole, and penicillin. The best answer for a patient with chronic graft-versus-host disease on prednisone 1 mg per kilo per day would be D. Acyclovir is recommended to prevent varicella zoster while on immunosuppression. Valacyclovir is an alternative but has less data to support. Valganciclovir as a prophylactic agent has more toxicity. PJP prophylaxis is indicated in this scenario. Pentamidine is inferior to sulfamethoxazole trimethoprim and should only be used in cases where a patient is intolerant or allergic. Because of the high-dose steroids, a mold-active azole is most appropriate, and the IDSA guidelines recommend posaconazole based on a randomized study showing superiority over fluconazole. Voriconazole has not shown superiority over fluconazole in this setting and has increased risk of adverse effects. Penicillin is appropriate for patients with chronic graft-versus-host disease on immunosuppression to prevent streptococcal infections. Transplant patients are a population at high risk for a variety of infectious complications. The risk of infection varies based on multiple factors, including the type of transplant, the time since transplant, their disease status and prior treatments, graft type, and the presence or absence of graft-versus-host disease for allogeneic patients. This table describes impairments in host defense and how it impacts infectious risk over time for allogeneic patients. In the early recovery or pre-engraftment phase, the conditioning regimen has frequently caused breakdown in the mucosal barrier, and patients are often neutropenic. They may also have central lines or other access points. So this period is dominated by risk of bacterial infections, including gram-positive, gram-negative, and anaerobic organisms, as well as herpes simplex and respiratory viruses. The main fungal risk during this period is with Candida species, although mold infections like Aspergillus can become a risk if neutropenia persists long enough. In the mid-recovery phase, neutropenia has resolved. Therefore, there is a lower risk of bacterial infections. Instead, cellular and humoral immunity have still not recovered, so patients in this phase are at risk for viral infections such as HSV, cytomegalovirus, and Epstein-Barr virus. Mold infections and pneumocystis are also a risk during this period. And the late recovery phase really encompasses patients who develop chronic graft-versus-host disease, as their immune systems remain suppressed with decreased cellular and humoral function, as well as functional asplenia. These patients are at risk for infections from encapsulated bacteria, many viruses, including varicella zoster, and mold and pneumocystis infections. Antimicrobial prophylaxis is a strategy to prevent infection in transplant patients, and the next several slides will walk through guideline recommendations to prevent various types of infections in these patients. The guidelines cited at the bottom of this slide are also a recommended reading for the module. Bacterial prophylaxis is divided into early and late phases. In the early phase, a fluoroquinolone with anti-pseudomonal activity is recommended if the anticipated duration of neutropenia is greater than 7 days, and that's for both autologous and allogeneic patients. After day 100, the risk of bacterial infections is primarily related to the diagnosis of chronic graft-versus-host disease and the functional asplenia that occurs. Therefore, patients with chronic GVHD who are on active immunosuppression should receive prophylaxis against Streptococcus. Penicillin is a commonly used option, although choice should be driven by local antimicrobial resistance patterns. The recommendations to prevent pneumocystis pneumonia differ between allogeneic and autologous recipients. For allogeneic patients, it is recommended to continue prophylaxis from engraftment through at least 6 months and longer if patients remain on immunosuppression. For autologous patients, prophylaxis can be considered for patients at high risk, such as those with hematologic malignancies, or if they have a history of high-dose steroid or purine analog treatment. And the duration can be 3 to 6 months after transplant. But regardless of the type of transplant, the preferred agent is sulfamethoxazole trimethoprim, as it has superior efficacy and also protects against pathogens like nocardia and toxoplasma. Prophylaxis against fungal infections is divided into yeast and mold prophylaxis, so looking first at yeast prophylaxis. For autologous transplants, this can be considered for patients with expected prolonged neutropenia and mucosal damage from the conditioning regimen. And the recommended agent is fluconazole 400 milligrams per day from the start of conditioning through engraftment. Fluconazole prophylaxis should be given to all allogeneic patients, starting with the conditioning regimen and continuing at least through day plus 75. Acceptable alternatives that are included in the guidelines are micafungin, itraconazole, voriconazole, and posaconazole. Mold prophylaxis should be considered for allogeneic patients who are deemed high risk. This is defined as patients with prolonged neutropenia, so think cord blood patients or patients who were profoundly neutropenic prior to transplant, and also patients with graft-versus-host disease who are receiving treatment. The Tomlin guidelines divide prophylaxis into pre- and post-engraftment and recommend micafungin for prophylaxis in the pre-engraftment state and posaconazole and voriconazole alternatively in the post-engraftment period. It is important to note that these guidelines were published before the availability of the posaconazole delayed release tablets. A more recent guideline is the 2016 Infectious Diseases Society of America Aspergillosis Guideline. Here, posaconazole is a strong recommendation with high-quality evidence as a first-line prophylactic agent for both patients with prolonged neutropenia and those with graft-versus-host disease. And this was based on a randomized study showing posaconazole was superior to fluconazole for prevention of aspergillosis and deaths from invasive fungal infection. Alternatives include voriconazole, micafungin, and itraconazole. Moving to antiviral prophylaxis for herpes simplex and varicella zoster, acyclovir prophylaxis is recommended for seropositive patients and should continue until resolution of mucositis. For varicella prophylaxis, it is recommended to continue acyclovir 800 mg twice daily for the first year post-transplant in allogeneic and autologous patients, or until off immunosuppression for 6 months in allogeneic patients. Either a prophylactic or preemptive strategy can be employed to prevent the development of CMV disease in allogeneic transplant patients. Ganciclovir IV is the recommended prophylactic agent in the guidelines, and while this strategy has shown reduction in CMV disease, it has not demonstrated an improvement in overall survival and is associated with pretty significant toxicity. However, in 2017, there was a new drug approved for prevention of CMV, letermovir. This was FDA approved for CMV prophylaxis in CMV seropositive adult allogeneic transplant patients due to a significant reduction in clinically significant CMV infection. It's important to note its spectrum of activity is limited to CMV, but it does have a favorable side effect profile compared to our other anti-CMV agents, with a similar adverse event and discontinuation rate seen to placebo. Many institutions will continue to utilize a preemptive approach, where anti-CMV therapy is started only after evidence of reactivation of the virus. Now we'll talk about a few non-infectious complications that can occur following transplant. Sinusoidal obstruction syndrome, or SOS, is caused by damaged hepatic endothelium and is characterized by hyperbilirubinemia, hepatomegaly, ascites, and renal function impairment. There are many factors that increase the risk of developing, such as pre-existing liver disease, older age, a second transplant, and conditioning regimens containing high-dose total body irradiation, busulfan, or cyclophosphamide. Severe SOS has a mortality rate greater than 80%. Therefore, prevention is paramount, and there are multiple strategies to prevent SOS. Modifications can be made, including using a reduced intensity regimen, using PK-guided dosing for myeloablative busulfan, and avoiding hepatotoxins as able. One pharmacologic agent, ursodiol, has shown efficacy in reducing SOS in a systematic review, although it did not improve overall survival. But based on the relatively safe drug profile, ursodiol 12 mg per kilo per day through day plus 30 to 90 is recommended. If SOS develops, treatment includes supportive care measures such as sodium and fluid restriction, diuresis, and dialysis if necessary. Pain control with opioid therapy may be necessary for abdominal and right upper quadrant pain. And the only FDA-approved treatment for SOS is defibrotide, which was approved based on an open-label, historically controlled study where defibrotide improved day 100 overall survival over the historical control group. Transplant-associated thrombotic microangiopathy has been described at rates ranging from 2 to 25% following transplant, with poor survival rates of approximately 40%. Clinical features include thrombocytopenia, hemolysis, renal dysfunction, and neurologic complications. There are no controlled trials to guide treatment choices, therefore best supportive care is indicated. Decreasing or substituting calcineurin inhibitors or Sirolimus as possible causative agents is often the first step. And other treatment options include things like therapeutic plasma exchange, rituximab, or defibrotide. The last part of this presentation will focus on late complications of transplant and care of long-term survivors. Emerging indications for transplant and transplant of older patients with reduced intensity regimens, as well as improved supportive care, has led to an increase in the number of transplant survivors needing long-term care. You can see that some of the same complications in the early phase can also occur in the late phase, such as graft-versus-host disease and infection, but we will also focus on other organ systems that can be affected post-transplant. Here is our last audience question returning to patient number 1. KB is a 72-year-old woman with relapsed diffuse large B-cell lymphoma. She received high-dose BEAM-R conditioning followed by an autologous transplant. She is now 1 year post-transplant. She has no laboratory abnormalities on routine follow-up labs and no signs or symptoms of organ dysfunction. Which of the following screenings should KB receive for long-term complications at this time? A. Echocardiogram. B. Bone mineral density testing. C. Renal ultrasound. Or D. Pulmonary function tests. The best answer is B. Bone mineral density testing. An echocardiogram, renal ultrasound, and pulmonary function tests are not routinely screened for autologous patients and should only be done if clinical symptoms exist. The next several slides contain guideline-recommended screening and preventative practices for late complications of hematopoietic stem cell transplant. This guideline, one of the recommended readings of the module, focuses on complications that are seen in both autologous and allogeneic patients at least 6 months after transplant, and it is written for both the transplant provider and the general practitioner who may see these patients in practice. Looking at complications in specific organs or organ systems, there are 2 main ocular late effects, cataract development and Sicca syndrome. An eye exam by a specialist is recommended at 1 year for all transplant recipients, but this can be considered earlier in allogeneic patients with graft-versus-host disease. Surgical management should be completed for cataracts, and there are various symptomatic treatments that can be utilized for Sicca syndrome, and I refer you to the handout for chronic graft-versus-host disease treatments. Oral cavity complications after transplant are also common, including dry mouth and oral cancers. All transplant patients should have an evaluation by a dentist 1 year after transplant and then annually or more often if needed. And some management of dry mouth can include discontinuation of causative medications like antihistamines, antidepressants, some analgesics. You could also add medications that promote saliva production and excretion, or trial artificial saliva. Multiple complications are seen in the lungs, including bronchiolitis obliterans syndrome or chronic graft-versus-host disease, idiopathic pneumonia syndrome, and infection. Pulmonary function tests and imaging should be done in symptomatic patients. Long-term liver complications can include graft-versus-host disease, hepatitis, and iron overload, and it's recommended to monitor liver function tests every 3 to 6 months for the first year and then at least annually. And depending on the indication, treatment options may include ursodiol, phlebotomy or chelation, and rarely liver transplant. All transplant recipients should undergo a cardiovascular risk assessment at 1 year and at least annually thereafter, as they may have a higher risk of multiple cardiac and vascular complications compared to the general population. And further testing should be done in symptomatic patients. Treatment for complications like hypertension, dyslipidemia, and diabetes should follow national guidelines. Blood pressure should be monitored at each visit and at least yearly. And while on calcineurin inhibitors, dihydropyridine calcium channel blockers are effective blood pressure lowering agents. Hyperlipidemia should be screened for at 3 months and every 3 to 6 months for those with ongoing risk factors. And moderate or high-intensity statins can be utilized to achieve LDL and cholesterol goals. And diabetes should be screened for every 3 months in at-risk patients, and again, treatment should follow national guidelines. Renal or bladder dysfunction can present in many ways post-transplant, including chronic kidney disease, nephrotic syndrome, radiation nephritis, or infection. Renal function should be checked at 6 months, 1 year, and annually post-transplant, and follow up with a nephrologist if necessary. Hypothyroidism is an endocrine abnormality that is relatively common post-transplant. Thyroid function testing should be done yearly and if symptoms develop, and treatment with levothyroxine should be initiated if present. Adrenal insufficiency most commonly occurs in patients with prolonged and excessive exposure to corticosteroids. And in these patients, slow terminal tapering of steroids should occur, and stress dose steroids can be used in times of acute illness. Women should have a comprehensive gynecologic exam at 1 year and as needed, and for men, symptoms should drive further testing. Finally, bone mineral loss is a common finding after transplant. Routine bone mineral density screening is recommended at 1 year for all adult women, all allogeneic patients, and any other patients at high risk of bone loss, for example, with prolonged corticosteroid use. Repeat testing should be performed for those with recognized defects or ongoing risk factors. Preventative measures include calcium and vitamin D supplementation to achieve vitamin D levels greater than 30, physical exercise, fall prevention, and smoking cessation. And for those with osteoporosis, bisphosphonate therapy should be initiated. Secondary cancers are a devastating late complication of both autologous and allogeneic transplant, and nearly all cancer types have been described post-transplant. Given the high risk for secondary cancers in certain tissues, recommendations for screening that differ from the general population were published in 2015. For patients who have persistent GERD or dysphagia, and especially those on immunosuppressive therapy for greater than 24 months, an upper GI endoscopy is recommended to screen for esophageal cancer. An annual oral exam should be done to screen for oral cancers, and an annual physical exam for thyroid cancer. For patients who receive TBI or have prior chest irradiation, it is recommended to start breast cancer screening with mammography at age 25 or 8 years after radiation, whichever is earlier, but definitely no later than 40 years. Females should receive an annual Pap test and HPV DNA test. And skin cancers are also very common after transplant, so survivors should have skin exams completed at least annually. We also know that antibody titers to vaccine-preventable diseases decline in the years following transplant. Because of this, it is recommended to treat a post-transplant patient as one who has never been vaccinated and revaccinate based on the recommended schedule in the IDSA guidelines. In general, autologous and allogeneic patients follow the same schedule for revaccination. The main difference is that it is not recommended to administer live vaccines to allogeneic patients with active chronic graft-versus-host disease. We have now covered aspects of transplant ranging from pre-transplant workup to post-transplant survivorship care. That concludes the presentation. Thank you for participating.